Professor Winthrop, from a clinical perspective, what are the highlights of this year's ACR?
Well, there's lots of highlights. My personal highlights have to do with some of the infection abstracts here, particularly some of those around vaccination. My favorite was presented by Dr. Park yesterday, and Dr. Yoongbong Lee, some Korean associates of mine that I've been lucky to collaborate with the last 6 months or so. They presented data showing that if you stop methotrexate for 2 weeks, you can enhance the response to influenza vaccine. This is a very practical study. It perhaps is practice changing, and that you can take your patient, it's influenza season, stop their methotrexate for 2 weeks, and they'll have an enhanced response. And in that study, nobody flared their underlying RA. So this looks to be something I think that's exciting and something I'm going to use in my practice.
In yesterday's lecture, you spoke about managing and preventing infections in rheumatoid arthritis. What should rheumatologists have in mind when prescribing therapy, especially in regards to potential opportunistic infections?
Yeah, yesterday I tried to highlight a couple things. One, just give a global overview quickly of the differential risks, or actually the very similar risks, of most biologics with regards to not just serious bacterial infections, but also opportunistic infections such as TB, zoster, etc. I also highlighted the issue with JAK inhibitors, where they distinguish themselves. They look very similar to the biologics, but there is this heightened risk of viral infections, particularly around herpes zoster. Then I tried to, present some cases, the cases that I tend to see. People refer me cases, and there's lots of questions around how best to screen for TB or how best to screen for hepatitis B virus. How to manage people that are co-infected with Mycobacterium avium, for example. This is something that we're seeing more and more, particularly in the US. So I highlighted those and just talked about screening strategies and vaccination strategies, also around zoster, use of the currently approved Zostavax, as well as potentially studying the new vaccine that's to come.
Tomorrow you will present a study on tuberculosis and other infections of interest in patients with RA in the baricitinib program. What were the main findings and what conclusions can be drawn?
This is a very nice study. It's all the developmental program data from the RA program, both RCT and long-term extension data. We were able to look at incidence rates for TB and other opportunistic infections if people had taken placebo, but as well as 2 milligrams and 4 milligrams. The highlights were the rates seemed to be what they should be. There were similar incidence rates that we see from other biologic programs, as well as other JAK inhibitor programs. The rate of TB, I think, is elevated with JAK inhibitors. We saw that with tofacitinib. We see similar, 5 to 10 time elevation above background general population in endemic areas, which is what we saw with Berry. We've seen that with tofa. We've seen it with TNF blockers. So I think they're pretty similar. There was very little TB to no TB in hypo-endemic areas, or places like Western Europe or the United States, where the TB rate is very low. Otherwise, we saw similar infections to what we've seen with other JAK inhibitors. A lot of viral infections, herpes zoster particularly. I think there's one CMV case, and then some fungal infections that aren't surprising also to see, pneumocystis, etc. So I think the highlight there is some risk, and it's mild. These events are quite rare, and they tend to occur in places, particularly TB, in places with background risk.
You recently contributed to another study which investigated how TNF inhibitors may alter the natural history of ankylosing spondylitis. What is the impact of this therapy on comorbidities and extra-articular manifestations?
Well, I think the hypothesis there is a good one. I mean, it's that if you have people with AS and you're treating them with biologics, that you're going to prevent associated problems due to AS. For example, uveitis. The uveitis that comes with AS, can we prevent it? So that's our attempt, is to address that hypothesis with that project. It's real-world data, and the data that was presented is young. It's the descriptive part of the program. We still need to use propensity scores and match up apples with apples, meaning that comparing people starting TNF drugs who are very similar to people who haven't started TNF drugs, and see if there's any differential incidence in associated comorbidities and sequelae of AS.
Where will research in the field of rheumatology take us in the next decade, and what could be the most exciting developments?
I think this is where I think we'll go. I think we'll go to mostly oral therapies, the JAK inhibitors being the start of that. I think we'll go towards eventually maybe getting rid of prednisone. we shouldn't need to use it. I think we'll get to better vaccinations and better ability to both predict who's going to have infections associated with these therapies, as well as better being able to prevent them with not just vaccination, but also steering therapies towards people that have a better potential safety profile.
Okay, Professor Winthrop, thank you very much.
You bet. Thank you.